For logging in, and in this coming 20-30 minutes we will learn on what is the optimal treatment of an extended stage small cell lung cancer. At the outset, I would thank AstraZeneca for providing me this opportunity to speak on this difficult to treat topic. uh, As we all know, small cell lung cancer is a very difficult disease to treat. If you have 100 lung cancers, around 15 of them are small cell lung cancers, and the rest 75, the rest 85% of them are non-small cell lung cancers. Non-small cell lung cancers uh, are little slow growing. They're easily treatable in the sense patients do have a survival crossing 2 to 3 years. They are amenable for targeted therapies with tablets and immunotherapy in a big way. And chemotherapy, multiple chemotherapies work well. They have a long progression free interval. Somehow they make a journey crossing 2 3 years, and we had a recent data that nearly 15 to 20% of them even cross 5 years with the non-small cell lung cancer. But a small cell lung cancer is an entirely different ball game, and it's a different disease in that it happens exclusively in smokers, or there should be an evidence of tobacco exposure. So if you have a small cell and tobacco exposure is not there, then we suspect is it really a small cell. So that is the concordance with tobacco exposure and small cell. They usually have a small primary, or the primary is in the hilum, and they present with a very bulky mediastinal lymphadenopathy. They present with a superior vena cava obstruction. And the natural history of this disease is that the patient responds well to chemotherapy initially, but the disease comes back, and majority of them die within a year. So we are speaking of a very deadly disease in smokers that usually happens in elderly. Uh, they present with a chest mass, a mediastinal lymph node mass. They get diagnosed, they respond well to treatment, the disease comes back, and they die within a year. And median survival is around 9 months to 1 year before we had this immunotherapy coming into picture. It's one of the most difficult and deadly cancers that we know in oncology. Apart from leukemias, pancreatic cancers, gastric cancers, now we have small cell lung cancers, which is one of the deadliest diseases we have seen. And the patient just expires before even getting some progression free interval. So you can see small cell lung cancer. We basically classify small cell lung cancer into a limited stage and an extended stage. Uh, I will show you in further slides how a limited and extensive stage looks like, and you can see the PFS in the Indian scenario uh, uh, is around 11.4 months, and in Chennai it's around 6 months, and the overall survival is just 7.2 months. That's staggering. You can see a survival of less than 9 months. That's how dangerous this disease is. And so among small cell lung cancer, uh, if it is limited stage, it is 1/3, and extensive stage is 2/3. This is how we see, and this is how the limited and extensive is all about. Limited is it is limited to one lung, or I can say one radiation portal. Whereas extended is it is in both the lungs, it is beyond the lungs, and it is everywhere, and even brain also is involved so soon with this small cell lung cancer. So around 1/3 are limited stage, and 2/3 of them, the remaining, are extensive stage. They have extensive disease, bilateral lung, not only both the lungs, outside the thorax, into brain, into adrenals, bone, liver, everywhere. So very fast multiplying, show rapid spread beyond the chest, hematogenous spread, lymph node spread, difficult to treat. So this is what you can say. Most patients respond. So if the best way to treat this is basically a platinum based chemotherapy. We do a etoposide platinum based therapy, and in limited stage, you see the response rate is up to 90%, whereas the moment it is extended stage, the response rate just falls down to 50 to 60%. So 80% in the limited stage, and almost all the patient in extensive stage relapse, and they relapse within 6 months of the first line therapy. So this disease responds well. So if I treat nearly 60% of them, the extensive stage respond, but the disease again comes back within 6 months, and the patient dies within 9 months. And that is the problem with this treatment. They respond, but it comes back. So this is how the evolution of treatment of a extensive stage small cell lung cancer has evolved over a period of time. You can see platinum etoposide was there in 85, and then we have radiation coming up in the limited stage, and then we had topotecan IV, very toxic treatment, hardly followed nowadays. Even we have the oral formulation also in 2007, but a lot of marotoxicity, difficult to handle drug. And then we had prophylactic renal radiation coming up, because this cancer goes to brain soon. So there is a role of giving radiation before the disease spreads to brain. And then now we had nivolumab, that is immunotherapy, coming in 2015, and now in 2018 and 19 we had atezolizumab in 18, and now we have durvalumab coming up in 2019. So if you can add an immunotherapy component to this platinum-based therapy, we can improve survival, and that is what I'm going to say today. So the unmet need in small cell lung cancer is all of them die within 1 year. Very difficult disease to treat. Despite an initial sensitive chemotherapy, they respond well to chemotherapy initially, but the disease comes back within 6 months. And approximately 10% of patients present with asymptomatic brain mets, which contribute to poor prognosis. So this disease has a very early CNS spread. The disease spreads to brain. Therefore, if there is symptomatic or even some asymptomatic individuals, we can do a MRI brain, and there is a role of prophylactic cranial irradiation. And this is what is all about immunotherapy. So just to have a rough idea, cancer is an immunosuppressive disease. Cancer weakens our immunity by PD-L1 expression. If you can prevent the PD-L1, PD-1 interaction by drugs, which we call as the immune checkpoint drugs, then our immunity is strengthened. Then our immunity will counterattack. The T cells will attack the tumor cells and cause cell death. So one is chemotherapy, which works in all rapidly multiplying cells, and the other way is immunotherapy. Immunotherapy has no direct action on the cancer cell. Instead, it strengthens our immunity, or it prevents the weakening of cancer. Induced immunosuppression is taken care of by coming in between the PD-1, PD-L1 interaction, and this will cause immune strengthening, or it re-edits the edited immunity and causes immune-mediated cancer cell destruction. So this is the study I was speaking of. So we have etoposide and platinum in the first line setting. We have irinotecan, platinum, also the evidence is there. And then we had atezolizumab plus cisplatin plus etoposide, atezolizumab carbo-etoposide in the advanced setting in 2018, the IM Power study, and now we have durvalumab with etoposide and platinum. So basically, these are untreated extensive stage small cell lung cancer patients. There were 800 odd patients. It was a phase 3 open label global randomized multicenter study. It's a big study of 800 odd patients. The randomization was into 3 arms. Durvalumab 1500. You can look into the doses of durvalumab, which is quite high with small cell lung cancer. Durvalumab, tremelimumab, and etoposide platinum. So tremelimumab is a CTLA4 antagonist, and the data is not available. So we will focus on the upper and the lower arms. So what if you give only EP, or you give EP plus durvalumab? So you can focus on the upper yellow color box, where you have durvalumab 1500 milligram plus etoposide platinum every 3 weekly up to 4 cycles, followed by durvalumab maintenance uh, and this is 4 weekly dose. Again, you can focus on the frequency of durvalumab in small cell lung cancer. And then you have the lowermost box where you see only etoposide platinum for every 3 weekly for up to 6 cycles, followed by optional PCI being there. So this is one of the unique trials where they have used both cisplatin and carboplatin. That was upon the discretion of the physician. The primary endpoint, as expected, should be overall survival because this is a deadly disease. So overall survival is the primary endpoint. Secondary endpoints are PFS, response rates, overall survival at 18 months, quality of life, safety, and tolerability. And then there were exploratory endpoints based on PD-L1 expression with and without brain metastasis. This was stratification and exploratory endpoints. So these were the baseline characteristics. You can see the baseline and the demographic characteristics are well matched. You can see the age is around 60 years. Majority of them were males. And what you can notice, yes, there were Asian patients also. Around 15% of them were Asian patients. And then 0 and 1 performance status was there in around 63% had PS1, and then majority of them, 90%, had stage 4 small cell lung cancer. And what you can notice, nearly more than 90% of them did have a smoking history. And then brain metastasis was present in 10% and liver mets in 40%. So this is the way in clinic the patient is sort of an elderly male with a history of smoking, presents with brain mets in 10% patients and with a performance status of 1. This is the classical presentation of an extensive stage small cell lung cancer in the clinic, and that's how it is reflected in the clinical trial. Again, what you can notice, nearly more than 75% patients received carboplatin, and cisplatin was around 25% patients. And you can note the number of chemotherapy cycles, it was less as per the design. Nearly 86% patients received 4 cycles, whereas in the nearly 56% patients received 6 cycles in the chemo arm. So the number of platinum exposure was higher in the chemo arm versus the durvalumab arm. So we have the component of extra chemotherapy in the chemo arm when compared to the durvalumab arm. And you can see the median total duration of durvalumab in weeks is 28, and median number of doses is just 7. So we always say the patient that you have to go on taking until progression, and this is the median number we have, just 7, not much. So this is the number of patients who had ongoing chemotherapy, and then this is the number of patients, those who received subsequent therapy. Nearly 50% of them with subsequent therapy, and even more than 2 was received nearly 20%. So yes, this reflects the real world practice where subsequent second line is received in 50%, and furthermore lines are received in nearly 20%, and this reflects the real world practice. So this is the overall survival. So you can see the clear-cut separation of the survival curves, and the curves become wide as you go down. So you had 100% patients surviving. As you followed up for up to initial 6 to 7 months, the curves did not separate because the chemo arm was working over there. And the moment you followed them up longer, at 1 year, at 1.5 years, and at 2 years, you can see that immunotherapy does significantly well, not in the initial part, but as you continue to follow them up, and you can see the tail of the tail that is just parallel to the baseline. So we have some 25% patients who are going to do with small cell lung cancer are going to do well, and they're surviving up to 3 years, and that is what immunotherapy is all about. So we all know immunotherapy works in around 30-35% patients, and in whom it works for longer and longer. So that is the uniqueness of immunotherapy, and that is what we have been seeing in this trial also. So you can see the initially you can see the crisscrossing of the red and the blue lines, but as you follow them up beyond 9 months, the x-axis is the time duration, the y-axis is the number of patients. So as you follow them up horizontally up to 1 year, so beyond 6 months there is separation. So the separation happens later on. So you don't see the results of immunotherapy in the initial 6 months. You see them after 6 months. So in practice, we do have patients with small cell lung cancer who are doing well, who go on and on to receive immunotherapy, and we see this not in 100% patients, in around 30-35% patients of small cell lung cancer who would otherwise die within a year uh, uh, do live longer with immunotherapy. And this is one of the big researches and developments in the treatment of small cell lung cancer, which we never saw for decades together. So this is the tail of the tail and the parallel lines, and 30%, more than 20% patients living up to 3 years. And this is the forest plot, and you can see all the subgroups have benefited, irrespective of what was the platinum used, whether cisplatin, carboplatin, what was the age, gender, performance status, smoking status, brain metastasis, liver metastasis, stage, race, region, everything, all subgroups. Durvalumab did better than the chemo, etoposide platinum arm. This is the response rates. Again, that is not the way we look into immunotherapy. We don't expect a greater response rates, but however, you can see an improved response rates with the odds of 1.53, and that is what that is not the main intention of immunotherapy. We don't expect early things, but having said that, there were improved response rates as far as the durvalumab arm was concerned. So this is the progression-free survival you can see over a period of time. So we spoke of overall survival. So in a small cell lung cancer, overall survival is the primary endpoint because we get the event early, and this is the progression-free survival. Even here you can see the progression-free survival being statistically significant with a hazard ratio of 0.8, 5.1 versus 5.4 months. So, however, it was not formally tested for statistical significance in this particular study. 56.8% of patients in the control arm received 6 cycles of EP. So there was there was more platinum and more chemotherapy in the chemo arm. So it was not statistically tested, but however, you can see the difference with a hazard ratio of 0.8. So the primary endpoint was overall survival, and that was statistically significant. So durvalumab plus etoposide plus platinum consistently improved overall survival versus etoposide platinum in patients regardless of brain metastasis. And you can see in brain mets, the median overall survival is 12 versus 8.8. However, the hazard ratio is crossing unity, but has a hazard ratio of 0.69. And you can see the blue and the red lines touching each other at the end. But if you look into in those patients where there were no brain mets, there was a statistically significant overall survival difference, hazard ratio of 0.74 and narrow confidence intervals. So you can see the forest plot in brain mets and also in patients without brain mets. There has been a significant benefit with durvalumab plus etoposide plus platinum. So PFS was also consistently improved with durvalumab plus etoposide plus platinum, regardless of baseline brain mets. With brain mets, hazard ratio is 0.73. Without brain mets, it was 0.78. So the median doesn't, the confidence interval do not cross the unity with without brain mets, whereas it crosses unity with brain mets. So impressive PFS, impressive overall survival benefit with the durvalumab arm. So we all know immunotherapy is not that toxic like chemotherapy. However, it has its unique side effects of immunotherapy related. You can see the difference, hardly much difference in toxicity profile with durvalumab. So there was a IO arm of durval tremelimumab. So maybe in those occasions there can be increased toxicity. Otherwise, the toxicity were in par and expected. There were no new safety signals as such. So the grade 3-4 was in 60-60, around serious adverse events in 30, and adverse events related to discontinuation was in 10%, and immune-related adverse events was in 20% versus 2.6, and adverse events leading to death was in 4 versus 5.6, because there was more chemo in the EP arm, and that may be the reason why little more toxicity seen in the chemo arm. So again, the use of colony stimulating factors and blood transfusions were more in the chemo arm because they received extra 2 cycles when compared to the durvalumab arm. So based on this trial, where we in the extensive stage small cell lung cancer, where the primary endpoint of overall survival was met, uh, durvalumab is approved in treatment naive patients with extensive stage small cell lung cancer. Durvalumab plus etoposide plus any platinum, whether cisplatin or carboplatin, could have been used. And the risk of death was reduced by 27% with a hazard ratio of 0.73 and narrow confidence interval with a p-value of 0.0047. And the overall survival was 13 months versus 10.3 months. So we are seeing overall survival crossing 1 year with this particular immunotherapy combination. So we all, when we explain to the patient, we all say that 10 months becomes 13 months. So just a 3 months extra. So this is not the number we use for an individual patient. This is a statistical way of explaining. Some patient may cross even 2 years, and some patient may even up to 3 years. So this is just a statistical way of putting the significance in front of us, but we shouldn't explain the patient that you have only 3 months extra survival. So that is not the way we put to the patient. So we can say to the patient that you take off all biases, you have a randomized trial, and there is a statistically significant improvement in overall survival. This absolute number is not for an individual patient, it is just a statistical value for a group. So that is what we say our patients. So this is the IM power study. So before durvalumab was there in small cell lung cancer, we had atezolizumab, which was there, atezo carbo etopo. What you can note here is the platinum is carboplatin and not cisplatin. We may not be able to use carboplatin in everyone because carboplatin is a little more marotoxic. Etopo, carbo both have marotoxicity. So in those subgroup of patients, we may have to use cisplatin. And cisplatin has little more response rates when compared to carboplatin. So in a younger patient with the renal functions are good, we may use cisplatin instead of carboplatin. So atezo trial has used only carboplatin and not cisplatin. So this is the difference of an IM power 133 versus the previous trial, which I discussed with durvalumab. So even this trial also showed statistically significant progression-free survival, and also statistically significant overall survival with a hazard ratio of 0.70, and the median overall survival was 12.3 versus 10.3 months, similar to the data which we saw with durvalumab. So choice of immuno-oncology drugs for extended stage, extensive stage small cell lung cancer. So we have Caspian study 12.9 versus 10.5 with a hazard ratio of 0.75, and we have IM power 133, the OS being 12.3 versus 10.4, the hazard ratio of 0.76. And the 18 months overall survival was 32 over here and it is 34 over here, and we have a 24 months overall survival, 22% with the durvalumab arm. So comparable overall survival. So what we can understand from these trials is that chemotherapy, so we had tried improving survival in small cell lung cancer by augmenting the dose of chemotherapy, by increasing the number of cycles of chemotherapy, by adding radiotherapy, by giving maintenance chemotherapy. None of them actually improved survival. Instead, we need to think out of the box, and if you can add immunotherapy to the chemotherapy combination and continue immunotherapy maintenance post platinum based therapy, you can see a statistically significant overall survival benefit, which we had never seen with any treatment for decades. So you can see in both atezo and also in the durvalumab trials, the separation is not in the initial part. You don't see the benefit with this immunotherapy in the initial part. The separation happens beyond 6 months. So that is how immunotherapy works. So immunotherapy doesn't cause a better PFS or a significantly different PFS or a significantly improved response. What it does is it improves overall survival, and the overall survival improvement is taken up by the tail of the tail population, where 20 to 30% patients who are going to benefit, they're going to benefit long, and that is the one that drives the whole overall survival towards the immunotherapy arm. So with this, I would like to uh, so this is again the comparison where what you can say is PCI allowed in the experimental arm with the IMPower study, and cisplatin was used in the uh, uh, Caspian study, the durvalumab study. So Caspian study inclusion criteria is reflective of real world clinical practice. Allowed cis or carbo include patients with either symptomatic or untreated or treated brain metastasis, compared against up to 6 cycles of chemotherapy and optional prophylactic renal radiation. So Caspian study reflects more of a real world scenario than an IMPower study. So this is the NCCN evidence what we have carboplatin, etoposide with durvalumab for 4 cycles, followed by maintenance durvalumab 1500 milligram every 28 days. And then we have cisplatin also with durvalumab, again for 4 cycles, followed by durvalumab maintenance. So, and also you can see atezolizumab only with carboplatin in the upper regime. So this is the preferred regimens which we have. Durvalumab is approved in combination with both cisplatin and carboplatin, whereas atezo is approved only with carboplatin. And you can note atezo is every 21 days, whereas durva is every 28 days in small cell lung cancer. So to conclude, first line durva plus etoposide plus platinum has shown improvement in overall survival, uh, and the control arm used 6 cycles that reflected the real world data, and durvalumab is the only immunotherapy that has flexibility of choosing cisplatin or carboplatin. Benefit with durvalumab plus etoposide platinum was observed across all subgroups, including brain metastasis. More than 22% patients on durva plus etoposide platinum arm are surviving beyond 2 years, and durvalumab Imfinzi plus etoposide platinum had higher response rate, demonstrated ongoing responses at 2 years is more than 3 times than that of the etoposide platinum arm. So durvalumab offers convenient once monthly dosing regimen in the maintenance phase. Safety findings remain consistent with a known safety profile of durvalumab, etoposide, and platinum. So this is the new standard of care and has its advantages of using cisplatin every 4 weekly, longer follow-up, and impressive data. So with this, I would like to thank everyone for their patient listening, and the take-home message should be for small cell lung cancer, etoposide platinum was the standard of care, followed by optional PCI. But now we have immunotherapy in place. We have both durvalumab and atezolizumab, both approved. Whenever it is possible, we must put immunotherapy in place to add life to the patient. Thank you, everyone, for your patient listening.